Hello viewers, I am Dr. Rabiul. I work as a lecturer in pathology in a medical college hospital, and I am making this video for my students and also for you. Hope someone finds this helpful. Today's topic is wound healing part 2. In this video we will discuss about cutaneous wound healing, which will obviously include discussion on healing by first intention, healing by second intention, their differences, followed by discussion on factors affecting wound healing and complications of repair. Okay, so let's begin. So first we will start with cutaneous wound healing. How does healing occur in our skin after it has been damaged? So cutaneous wound healing occurs in 3 phases. They are the phase of inflammation, that is followed by phase of proliferation, and that phase is followed by phase of maturation. But one thing you have to remember, these separations are not absolute. As a matter of fact, these separations into different phases, that separation is a bit arbitrary, and often the phases overlap. And one additional thing you have to remember, that one special event occurs prior to all these phases, and that is the event of blood clotting and hemostasis. So also keep that thing in your mind. Now, to say briefly about these phases, during the phase of inflammation, the inflammatory cells are the dominant cell type, and when we will look into the phase of proliferation, we will see that during the phase of proliferation, there will be proliferation of fibroblast, new blood vessels, which will form granulation tissue, and also there will be proliferation of epithelial cell, which will help in the process known as re-epithelialization. And during the phase of maturation, there will be extracellular matrix deposition, tissue remodeling, and also in case of healing by second intention particularly, there will be also wound contracture. So we will talk about these things in more detail after a while. So now that we have mentioned the key phases of wound healing, it will be easy if we discuss cutaneous wound healing under 2 broad headings, and they will include healing by first intention and healing by second intention. So first we have to know, what do we mean by healing by first intention? We will say that healing by first intention has occurred if a wound has the following criteria. So what are the criteria? Number 1, the wound has to be clean cut wound. Number 2, it has to be uninfected. Number 3, the cut margin has to be closely apposed with one another, say for example with the help of surgical suture or by other means. And number 4, there has to be very limited amount of tissue loss. So if these criteria are fulfilled, then that wound will heal by healing, and that will be healing by first intention. And also remember, healing by first intention is also sometimes called primary union also. So now that we have defined what do we mean by healing by first intention, now we will discuss its different steps and events. So to explain the different events of healing by first intention, you can see that I have drawn a series of images on the left side of the board. So on the first image, this is the wound. You can see that this wound looks like a clean cut wound, and also notice the cut margin. The cut margins, one on this side and one on the other side, they are closely opposed with one another. So here healing by first intention will occur. So what will be the events in healing by first intention? First, the wound site will be filled with blood. Then immediately after the wound has occurred, that wound will be filled up with blood, and then that blood will clot. and there will be platelet, entrapted red blood cell, fibrin, fibronectin, complement component, etc., among other things in the newly formed clot. And what is the purpose of this blood clot and hemostasis? Obviously, one function is to prevent bleeding, and then another purpose of forming this blood clot is to seal the wound from dehydration and seal the wound from further infection. And also it has a second role, and that is the clot can also act as a scaffold that the migrating inflammatory cells can use later. So always remember these three functions of the clot when we talk about wound healing. The examiner may ask you what is the role of blood clot in wound healing. Then you have to say that first of all, it prevents further bleeding, it stops the bleeding, and second, it acts as a seal that prevents dehydration and infection, and also it acts as a scaffold that inflammatory cells will use in the later steps of wound healing. So that thing occurs first. Immediately after injury, there is hemostasis and blood clot. What will happen next? Next, we will move on to the inflammatory phase, and during inflammatory phase, inflammatory cells will migrate and come to the site of injury. Among the inflammatory cells, there will be neutrophil. So within 24 hours, neutrophil will come to the site of injury. Now, a lot of my students ask how neutrophil will come to this site of injury. And always remember, they are circulating in the blood, so they will come out from the blood, and then via chemotaxis they will migrate to the site of injury. And there are a lot of events that occur, and we will talk about that hopefully in another lecture on inflammation. So for today's cutaneous wound healing lecture, just remember that during wound healing, first there was formation of blood clot and hemostasis. Then there was the phase of inflammation. During the phase of inflammation, inflammatory cells, mainly neutrophil, migrated to the site of injury from blood vessel. But one thing you also have to remember, neutrophils won't stay here for long. As a matter of fact, by the third day, neutrophils will be replaced by macrophages, and we will talk about that more after a while. So what will neutrophil do when they have come to the site of injury? The function of neutrophil will be to release proteolytic enzymes that will degrade the cell debris and also invading bacteria present in the wound site. So all these things will happen within the first 24 hours. Then what will happen? Within 24 to 72 hours, fibroblast will begin to proliferate. So we are now moving on from the inflammatory phase to the proliferating phase. And fibroblast will proliferate, and with fibroblast there will be also proliferation of new blood vessels, which is known as angiogenesis. And fibroblast together with proliferation of new blood vessel will later form a specialized tissue which is known as granulation tissue. Granulation tissue will appear as pink, soft and granular in pattern, and from that it got its granulation tissue name. So as you can see in the second image, I have drawn fibroblast here, and I have also drawn that in a larger scale on the far left of the board. So this is how a fibroblast looks like. It is a long slender cell, and it will begin to appear, it will begin to proliferate from 24 to 72 hours. And also there will be proliferation of new blood vessels. So here you can see there are some proliferation of new blood vessel as well. And together they are forming granulation tissue, which you have to remember that is the hallmark of repair. So if the examiner asks you what is the hallmark of repair, then you have to answer that is granulation tissue, which is composed of proliferating fibroblasts as well as new blood vessels. Now, one thing you may be asking that where does these fibroblasts come from? So some proliferate from local fibroblasts, and while some others migrate here due to stimulation of some growth factor, and I will list those growth factors at the end of today's video. So those things are happening within 24 to 72 hours. Now, one thing you have to remember, during the proliferation phase there will be also proliferation of epithelial cells. Now, how does that thing occur? After 24 hours, initially there will be migration with little proliferation of the basal epithelial cell. So this is the basal layer of the epithelial cell. This is another basal layer, and after 24 hours the cells, the basal epithelial cells from both cut margin at first will begin to move. They will migrate along the cut margin, and as they are moving they will also deposit basement membrane, and ultimately they will come from both ends and they will fuse in the midline. So by 48 hours the wound will have at least a single layer of epithelial cell, as drawn here. You can see that this is the single layer of basal epithelial cell that has fused the wound, and by the 5th day this layer will become multi-layer. However, it takes a longer time to fill the entire wound with re-epithelialized cells. So also keep that thing in your mind. And you also have to remember that fibroblast proliferation and fibroblast migration that I had just mentioned a few while ago, that also depends on a lot of growth factor. Those growth factors include cytokines, platelet-derived growth factor, which is also called PDGF. It also depends on TNF, FGF, TGF, beta, etc. So all these growth factors are required for migration of the fibroblast, and also there are some other growth factors which are responsible for proliferation of the fibroblast, and I will talk about those things at the end of today's video. But also remember that macrophages are the major source of most of these growth factors, and macrophage comes to this scenario on 3rd day and they replace neutrophil. So as you can see, I have also drawn macrophage here. You can see that this is a macrophage. You can see it's a very large cell nucleus on side, and also here you can see I have also drawn neutrophil that you usually see in the first 24 hours. How can we know that this is neutrophil? Neutrophil has 3 to 5 lobes. It's neutral in color. You can see that the cytoplasm looks neutral, and from that it got its name neutrophil. But also in the cytoplasm there are some fine pinkish granules, because this is in fact a granulocyte. So also keep that thing in your mind, the appearance of a neutrophil within 24 hours, and by the 3rd day that is replaced by macrophage as well. Now, one important thing you have to remember, at the same time when we are seeing epithelialization, another important thing is happening, and that is the fibroblasts are releasing collagen fibrils, and those collagen fibrils will then begin to bridge the incision. So collagen fibrils will be released and they will begin to bridge the incision. And in your textbook you will also see 2 types of matrix. The first matrix is known as the provisional matrix, and the examiner may ask you what are the components of the provisional matrix that we see during wound healing. Then you have to say the provisional matrix will contain fibrin, fibronectin, and collagen type 3. Okay, so also remember this important point. It will contain fibrin, fibronectin, and collagen type 3. And later the provisional matrix will be replaced by a second matrix, and there we will have collagen type 1 instead of collagen type 3. So also keep that thing in your mind. Now let's move on and let's see what happens in the last image, and that is showing things happening within weeks. So moving on to the last image of healing by first intention. This is occurring during the phase of maturation. Now can you see any big difference with this image and the previous two images? Yes, there is almost no inflammatory cell. Look, in the first phase we had neutrophil, in the second phase we had macrophage, but they are now gone. As a matter of fact, during the phase of maturation, the majority of the inflammatory infiltrates are now gone. The blood vessel proliferation that we had seen in the first phase, that is also gone. And there is formation of the scar tissue in the phase of maturation. Now, in scar tissue, what will we see? The granulation tissue will be replaced by dense collagen material. As a matter of fact, the granulation tissue that we had seen in the previous two phases, that tissue had acted like a scaffold for the collagens to deposit. Initially, we will see a provisional matrix that will contain fibrin, fibronectin, and collagen type 3, but later the collagen type 3 will be replaced by collagen type 1, and there will be formation of a scar tissue that will have no inflammatory infiltrates and very diminished amount of blood vessel. So by the end of 2 weeks we will see those changes and scar tissue will be formed. Another important thing that happens during this last phase of maturation is wound contraction, and wound contraction is particularly seen in healing by second intention, where there is a large gap between the cut margins. However, we may see little bit of wound contraction in first intention as well. Now, the idea behind wound contraction is to reduce the area or the gap between the two cut margin. And in order to achieve wound contraction, a special type of cell plays a key role, and that cell is called myofibroblast. Recall that myo came from muscle. So this is a cell that has intermediate characteristics between smooth muscle cells and fibroblast, and that can contract and wound even as much as 80%. The last thing that I will discuss regarding healing by first intention is the strength of the wound site after it has been healed. So the fibrillar collagen, particularly the type 1 collagen, is the key molecule to provide the strength of the wound. And by first week, 10% tensile strength of the original tissue is achieved, and then in the next 4 weeks there is a rapid progression of the strength, and by the third week a plateau has been reached and about 70 to 80% strength of the original tissue is achieved. So also remember those important percentages for your exam. So now that we have discussed about healing by first intention, we will discuss briefly about healing by second intention. And as we will see, the major steps are almost similar. There will be some dissimilarities, and that we will focus on. So as you can see from the second line of images, these are showing healing by second intention. So the majority of the steps are the same. So first there will be formation of blood clot. So this one is the area of the blood clot. It has formed to protect the wound from dehydration and further infection. Then there will be infiltration of neutrophil. This is also same within the first 24 hours. But the difference is, since this is a large wound, so we will need a lot of granulation tissue and a lot of other cells. So here we will see more proliferation of the blood vessels, and we will see huge amount of fibroblasts coming to these areas. There will be a lot more inflammation compared to healing by first intention. So you can see more cells have came to the site of injury. There is more blood vessel proliferation compared to healing by first intention. And there will be increased amount of granulation tissue formation, obviously, to fill up the big gap. So what do we mean by healing by second intention? The wound will have not a clean cut, it will have an unclean cut margin, irregular cut margin. There may be often presence of infection, and the cut margins will be not closely opposed. There will be a big gap between them, and a lot of tissue will be lost. And in those cases there will be healing by second intention, and the major difference with that with healing by first intention is there will be increased amount of granulation tissue formation, and there will be a lot more inflammation present. And also wound contraction will have a very vital role in healing by second intention, to close the cut margin by contracting the wound site. So now that we have discussed briefly about healing by second intention, we will now just say briefly the difference between healing by first and second intention. And I think you obviously know most of them by now. So first, the cut margin. In case of healing by first intention, it is a clean cut wound. In case of healing by second intention, it is not a clean cut wound. Healing by first intention, there will be no infection, but there may be infection present in healing by second intention. Granulation tissue will be formed in small amount in healing by first intention, whereas in healing by second intention, there will be large amount of granulation tissue formed. The cut margins are closely opposed in healing by first intention, and not closely opposed in healing by second intention. And there will be very few complications in healing by first intention, whereas in second intention there can be a lot of complication, and ugly scar may be formed. So we can classify the factors influencing wound healing under two broad headings. They are systemic factor and local factor. Among the systemic factors, there is first nutrition. Recall that if there is protein deficiency, malnourishment or vitamin C deficiency, that will diminish wound healing. Recall that vitamin C is vital for collagen synthesis. The second systemic factor that I will mention is the metabolic status of the patient. Say for example, if the patient has diabetes, he or she may have some abnormality in the small blood vessels, and that will diminish blood supply and hamper wound healing. The next systemic factor that we will talk about is hormonal factor. Say for example, some hormones have anti-inflammatory effect like glucocorticoids, and they can hamper wound healing. The fourth point is regarding the vascular condition. If the patient has, say for example, atherosclerosis or varicose vein, that is dilation of a vein where blood is pooling and not draining properly, so in those cases the patient will end up with diminished blood supply, and that will also hamper wound healing. Among the local factors that can influence wound healing, first point is regarding infection. If there is presence of infection, there will be persistent inflammation, and that will hamper wound healing. Early mobilization can also be considered a second local factor. If the wound site was mobilized too early, that will make the cut margins apart from one another, and also sometimes movement can compress blood vessels around the wound site and also cause delay in wound healing. The third local factor that I will mention is regarding foreign body. Say for example, presence of glass, presence of some foreign substance, even bone can hamper wound healing. And the last local factor is regarding the location of the wound and the type of injury. And that's obvious. If the wound is located in an area that is richly vascularized or that has rich blood supply, say for example in the face, that will heal faster than a wound that is located in a poorly circulated area, say for example in the foot. And also a wound that is smaller will heal rapidly than a wound that is larger in its size. So now that we have discussed the factors influencing wound healing, now we will move on to the last topic and discuss the complications of wound healing. Now, one common complication of wound healing is wound dehiscence or rupture, and that occurs as a result of inadequate granulation tissue formation. It is sometimes seen when intra-abdominal pressure was raised, say for example after vomiting or coughing, and that can result in rupture of an abdominal wound due to increased pressure, and that occurs when there is decreased amount of granulation tissue formation, and that is known as wound dehiscence. Similarly, some complications of wound healing may arise due to excessive formation of granulation tissue and collagen. Say for example, when there is excessive formation of collagen, the wound may give a raised appearance, and that is known as hypertrophic scar. So hypertrophic scar will be formed due to excessive amount of collagen production, and that will be raised from the surface. Now, if the raised area is confined to the wound area, that is hypertrophic scar, but when the raised area goes beyond the boundary of the wound, then that is given the name keloid. And also remember, keloids are common in African American, and they do have a genetic predisposition. Similarly, excessive production of granulation tissue will protrude above the surface of the skin, and that is something known as proud flesh. Also, another complication that we see in the wound healing sometimes is known as wound contracture. Remember, we talked about wound contraction, that was normal, but when too much wound contraction occurs, that is known as wound contracture, and it is seen commonly in burn patient especially. So also remember about the difference between wound contraction and wound contracture. Too much wound contraction will result in wound contracture. So this concludes today's video about wound healing part 2. Wound healing is a very big topic, so I try to upload videos in part by part. I hope this video was helpful. If you like my videos, do comment, share, subscribe, and let me know. And for my students, I will also recommend you to go through your textbooks to know more information. So that's all for today. Until next time, take care and stay blessed. Thank you.